good evening to you all. Hello and welcome to yet another session of BRENDOS. Friends, BRENDOS is the Breast and Endocrine Society of Western Uttar Pradesh. It is a very unique program in its own sense, and I can proudly say that we are conducting it without any interruption for last more than 1 year. Breast cases on every even month and endocrine cases on every odd month. It is a platform where all the clinicians with a special interest in breast and endocrine pathologies, they all come together, join on a monthly basis on the last Friday of every month to discuss about these pathologies. As already told, we have distributed time, the even months for every breast cases and odd month for every endocrine cases. It is a problem-based learning program where we pick a problem of clinical relevance. We discuss about that problem in detail, but in a very simplified form so that everyone can understand what we are actually discussing about. We don't go into very hardcore data, try to simplify it so that everyone understands what data actually means. And we try to find out our learning objectives, what we actually want to learn from that presentation with the help of actual pathology, actual radiology images, with the help of their specialists like the pathologists, radiologists, who explain those images to us so that as a clinician, it brings an impact into our mind how these reports actually look like in the images, be it histophotomicrograph or the radiology images. Secondly, they also understand how their reporting has an impact on the clinical management and the ultimate outcome of the patient. So it is a multidisciplinary program. We provide the operative photos, the post-operative images, everything, the follow-up details. This time also we have picked up a very interesting, that is the benign breast lump. Why it is important? Because in any breast clinic, more than 90% of cases are benign, be it a benign breast lump or mastalgia. But in any dedicated breast forum, they hardly find any place for discussion because even the most dedicated breast surgeon, they feel since these are not life-threatening disorders, they need not to be discussed. But it is not like this because they may not contribute to the mortality, but they contribute a lot to the morbidity of the patient because we know health is not only the well-being of the physical health, but also mental health also. So they cause a lot of anxiety and other disorders in the female and the family who is harboring those disorders. So it is very important to understand about these benign breast lumps to provide right remedial measures so that the female is healthy by emotions also. Okay, so now I will not take much time because everything we are going to discuss in our program. I would like to introduce my moderator, Dr. Archana Goyal, and I'm very thankful to ma'am that she has kindly consented for our meeting. So I'm very thankful that she has kindly consented for our meeting. For those who hail from Meerut, they need no introduction of her. For those who are from outstation places, Dr. Archana Goyal is a senior gynecologist. She is a director of Siddhivinayak Hospital, which is a very renowned hospital of Meerut, and she is a very active surgeon and a very active and a dedicated academician also because she is member of Foxy and so many other forums that she is an active member. Also, she's an alumni from Government Medical College Surat and she did her DGO from Government Medical College Surat. She is a very renowned infertility expert and a laparoscopic surgeon. So, ma'am, thank you very much once again for kindly accepting our invitation to host this program as a moderator. And now, may I request you to take over the charge and introduce our guest speaker, guest faculties, as well as some important announcement if you want to make. Thank you. Muted, please. You can unmute yourself.
Thank you, Sudhi, for your kind words. And good evening, everyone. First of all, I pay my heartfelt gratitude to Dr. Sudhi for this opportunity and making me part of this webinar. Today, we are going to discuss a very important topic which troubles us in our day-to-day practice, evaluation of benign breast lump. As we all know, benign breast lumps are non-cancerous growths that occur in the breast tissue. They're quite common, and these lumps can include fibroadenomas, cysts, papillomas, lipomas, and others. While they may cause discomfort in the breast, but generally not associated with breast cancer. So for the discussion of this topic, we need multiple specialties to deal with it. So we have faculties from our city as well as from outside. Our first faculty is Dr. Sudhi A Kamboj. She's the consultant of Breast and Endocrine Surgeon, Newtown Hospital, Meerut. We have with us Dr. Chani Jain. She is the consultant pathologist at Shastri Nagar Diagnostic Center, Meerut. And Dr. Rupali Mishra, she is the consultant radiologist at Shastri Nagar Diagnostic Center, Meerut. Our first guest faculty is Dr. Pranya Voliveru. She is the consultant endocrine and breast surgeon, KIMS Hospital, Kondapur, and KIMS Gachivali, Hyderabad, Telangana. In a row, she is the recipient of Professor R.K. Sharma Award 2021 STPI, Breast Research Poster Award, Breast Surgery International 2019 in Poland, and Professor Jyoti Ramalingam Best Paper Award in 2018. Many national and international publications to her credit, and very interesting and unique topics like genotype-phenotype correlation in hereditary MTC, sentinel lymph node biopsy in breast cancer, and parathyroid carcinoma. She has also worked at Apollo Cancer Institute, Hyderabad, and at AIMS Delhi. Welcome, Dr. Ramya.
Thank you, ma'am.
Our another guest faculty is Dr. Mona Bajaj. She is additional professor in Department of Obstetrics and Gynecology, KGMU, Lucknow. She is the recipient of 2 gold medals, 1 silver medal, and 9 certificates of honor during MBBS. She has been felicitated with Dr. C.L. Javeri Award for Best Paper Presentation in AICOG 2020. She is the master trainer of gestational diabetes mellitus under a project, World Diabetes Federation, and various others also. She has presented papers in various national conferences. Her area of interest is high-risk obstetrics and infertility. She bags more than 35 national and international publications. Welcome, Dr. Mona, on this forum.
Thank you so much, ma'am, for your
We are
kind
highly elated to have you amongst us today to make this session more meaningful and fruitful. So before starting the session, I would request to all the delegates to keep their mic on mute, and so that we may have uninterrupted session. And if you have any interruption in between, you can join from the same link. And if you have any doubt or any query, you can write in the chat box so we can have better discussion later on. Thank you. Over to you, Dr. Sudhi.
Thank you very much, ma'am. Thank you very much, all the speakers and the guest faculties. So now I'm sharing my screen to all. So yeah, fine. So at the outset, I would again like to thank all my guest faculties, moderator, and my co-speakers for joining us today, and for giving an opportunity that we can discuss about this very important topic today. Friends, in today's presentation, what we are giving you is a overview of about benign breast lump, the epidemiology, the importance, why we are about to discuss these lesions, the various etiological factors, क्यों ये होते हैं, their clinical presentations. We will discuss in detail about fibroadenoma, one of the most important benign breast lump that we frequently see, and we will try to differentiate it from the phyllodes tumor if the time permits, and the management approach and what is new in the management of these lesions. So friends, now first understand what are lumps. Any discrete localized swelling in the breast which feels different from the normal tissue in the same area of the other breast. So this is very important. The same area of the other breast, usually the feel must be different. Okay. So this is important because sometimes patients say that it is lump, but it comes out to be some adenosis. So in that case, usually the lumpiness is bilateral. So this is something we would like to differentiate. So any lump, it could be either malignant or it could be non-malignant, that is benign. Breast lumps, they are very common in general practice. More than 25%, one-fourth of the females once in their lifetime are going to experience this phenomena. 90% of them are benign, but 10% may be malignant. The importance for the patient is that because of the presence of a palpable lump, they have a lot of anxiety and which lowers their work performance. And for us as a clinician, the importance lies to screen out malignancies from the benign lesions. Friends, we all know the risk of breast cancer increases with age. In a general population, जहाँ the risk of breast cancer in 30s is only 0.5%. In 60s, this risk rises to 3.54%. So with age, the incidence rises. Risk of breast lump being malignant is exceedingly rare in adolescents, very, very rare, but it is not absolutely no. One cannot say that under 20 years one cannot have breast cancer. The possibility is very low, but it could be a possibility still, right? So, what is our aim whenever any patient presents with a breast lump? First of all, we try to verify whether it is really a lump or a lumpiness. We try to see, like we have our own ways of doing that. Secondly, if the lump is there, we will try to rule out whether it is a solid or a cystic lesion. Reason, the management approach is entirely different in these two type of lesions, and the risk of malignancy also varies in between these two type of lesions. Thirdly, to rule out malignant from the non-malignant lesion. So there are various radiological and other pathological features through which we try to rule out a malignant from a non-malignant lesion. Now it is benign, we know it. Even if it is non-malignant, it is very important to identify the cause. It is not like कि अभी ये बस benign है, nothing, it is normal. This normal word is not right. Any lump is abnormal. It is important to identify the cause. Because, as I have already told, it is not only the sound functioning of the physical but also a mental health. So, if it is a palpable lump, the patient may not add to the mortality of the patient, but it adds to the morbidity of the patient by causing a lot of anxiety and emotional distress. So, it is very important to plan a treatment strategy to relieve the symptom. Friends, please note down this rule of thumb. Always give the possibility of malignancy or high risk lesion in any lump, all cases until unless proved otherwise. Okay. Now, if we talk about the causes, we all are familiar with the anatomy of the breast. It has a skin, subcutaneous tissue, adipose tissue, true breast tissue, then vascular tissue, and supporting stroma, muscle, chest wall, etc. So, any palpable lesion in the breast may arise from either true breast tissue or a fat tissue, vascular tissue, muscular tissue, chest wall, or even the pleural cavity. So sometimes the patient may present with a breast lump, which is in fact coming a cold abscess coming from the pleural cavity. So the thing is, we are not going to discuss any of these lesions except the true breast tissue related lumps that we are going to discuss today. It is very important to understand the physiology before we go into the pathology of these lesions. So, friends, we know breast has a very important aesthetic, sexual, and nutritious function, nutrition to the babies. But it is not a static organ. Once the puberty starts, it undergoes dynamic structural changes throughout the life. After menarche, there is expansion of the lobular system. Even after that, with each menstrual phase, lactation, pregnancy, it is a periodic remodeling because of the upsurge of estrogen, progesterone, prolactin, and other hormones. So it has a periodic remodeling throughout. So some part gets proliferated, other part gets regressed, something like this. Then it undergoes involution and regression following menopause in later stages of life. It is a symbol of femininity with social, cultural, and personal importance. That is why it is very important to know how we can treat any problem related to breast. Now, friends, the pathologies, to simplify the pathologies of the breast, we have divided the normal anatomy. Any pathology arises from either the two major structures, like two types of epithelial cells and two types of stroma. Understand? All our pathologies will arise from either the two major structures, two types of epithelial cells, and two types of stroma. I'm trying to simplify it as much as possible. So, what are these two major structures? These are the ducts and the lobules. Two epithelial cells are the luminal and myoepithelial, and two types of stroma are interlobular and intralobular stroma. Please don't worry. I'm going to explain all these one by one. So friends, this is the line diagram of the normal anatomy. These are the lobules from where the milk is produced, and these are the ductules through which the milk comes down. These are the major ducts. So please remember one very important term, that is terminal ductular lobular TDLU. This term is very, very important. First, we identify the anatomy of this term. This is the terminal ductular. These are the ductules, lobular unit, and these are the terminal ducts, subsegmental and terminal ducts. So this is the TDLU, the terminal ducts, ductules, and the lobule. Most of the lesions, they arise from this TDLU, terminal ducts, ductules, and lobules. It is also a basic functional and histopathological unit of breast. It is the unit which produces milk, and most of the benign and malignant lesions, they arise from TDLU. Then there are major ducts. Okay, so anatomically there are two different structures from which the lesions arise. Then there are two different stroma. Now once again, please look into this. This brown area is the lobule. So in between the lobule, then these are ductules. From the lobules, the glands, the acini, the milk is produced through these small ductules. Now the milk comes into the terminal ductule. So these are the ductules. This is the intralobular terminal duct, which because it is inside the lobule. Then this is the extra lobular terminal duct because it is outside the lobule. Okay, and this extra luminal, this area is the TDLU. So any stroma which is entrapped in between the acini, yeah, in the lobule, is called intralobular stroma or lobular stroma. Whereas any stroma which is outside the lobule, in between the two lobules, this is called interlobular stroma. Okay, so these are the two types of cells. So one type of cell, the epithelial cells, which faces the lumen of either the gland or the duct, is called the ductal cells, and the other cells which is outside the duct but underneath the basement membrane is the myoepithelial cell. So there are two different type of cells, the luminal or the ductular cells and the myoepithelial cells. This myoepithelial, they helps in contraction and propulsion of milk into the major ducts. Now, this illustration is very helpful and I found it really very helpful. This is the cut section of a broccoli. So these are the lobules. Inside the lobules are the intralobular terminal duct. This is the extralobular terminal duct, and this whole the TDLU. If we see histologically now in this, so this is the lobule. These are the intralobular terminal ducts. This is the extralobular terminal duct. In between the acini are the intralobular stroma, and outside the acini are the interlobular stroma. Same is with here. So there are two lobules full of acini. This is the extralobular terminal duct. These are the intralobular terminal ducts, and these are the intralobular stroma, and this is the interlobular stroma. I hope I am able to explain you, illustrate you all these things. Now friends, now this slide is very important. Very important reason. Most of the pathologies that we classify is based on the histology and the degree of cellular proliferation. So histologically, there are two types of cells through which the lesions arise. Either they are the epithelial lining cells or they are the stromal supporting cells. Sometimes we get a mixture of epithelial and stromal, which we call fibroepithelial cells, या proliferation. So epithelial में क्या होता है? It could be either benign or malignant. Benign could be non-proliferative or it could be proliferative. What does this mean? Non-proliferative means that the cells are not dividing, they are not proliferating, there is no hyperplasia, but there is hypertrophy or atrophy of the cells. Proliferative means there is proliferation, that is hyperplasia of cells. Now this proliferative, if the cells are without any atypical features, we call it proliferative lesions without atypia. But if the proliferative lesions, the proliferative cells started developing some atypical nuclear features, then we term them as proliferative lesions with atypia. Now, stromal या fibroepithelial benign lesions क्या होते हैं? These are fibroadenoma and phyllodes tumor. These are fibroepithelial because they have a component of epithelia as well as stroma, fibrous tissue. So therefore, they are termed as fibroepithelial. These fibroepithelial lesions, most of the time, are termed along with in the are categorized with the proliferative lesions without atypia most of the time. But in certain categories of phyllodes, malignant phyllodes tumor, we do get typical atypical cells. Okay, malignancy में we know अगर basement membrane is not breached, it is in situ CA. If it is breached, then it is invasive CA. So anyhow, it is a cancerous lesion. If it is confined within the basement membrane, it is in situ. If it is breached the basement membrane, it is invasive. So अब हमारा ज़्यादातर discussion इसी background के through होगा. Now अब नॉन प्रोलिफरेटिव लीजन ऑलरेडी आई हैव एक्सप्लेन कि ये क्या होते हैं. व्हाट इज द इंपॉर्टेंस नॉन प्रोलिफरेटिव लीजन? बिकॉज देयर इज नो प्रोलिफरेशन ऑफ सेल, the risk of malignancy is not that in those lesions. You may say practically nil. So if such lesions are there like cyst, अब इसमें lesions क्या होते हैं? इसमें होते हैं cyst. Cyst means कि there is a because of hormonal stimulation the cells become hypertrophied. Later on the hormonal stimulation comes down, the cell is supposed to now atrophy, but certain amount of fluid remains in those glands. Those become cyst. Cyst sometimes ruptures, lead to surrounding inflammation, fibrosis, surrounding inflammation, sometimes pains, and fibrosis. Then it is adenosis, means the number of acini are increased per unit of the tissue. So there is no proliferation of cells, but the acini, जो glands हैं, वही बढ़ गए हैं. So these patients we usually find like they have some localized lump. They say there is lumpiness, but there is no lump on ultrasound. But there is some localized collection of tissue, but there is no discrete lump. That is obviously non-sclerosing. And duct ectasia. Duct ectasia, की duct is dilated, and when we press it, some nipple discharge comes out. We will discuss in detail about nipple discharges somewhere down the lane. Right now, we just understand that duct ectasia is a non-proliferative lesion with no risk of malignancy. Now comes the proliferative lesions without atypia. Friends, if the proliferation has started in the breast tissue, the risk of malignancy becomes 1.5 to 2 times compared to those breast tissue where there is no proliferation. तो अगर proliferation नहीं है और proliferation शुरू हो गया है, the risk of malignancy automatically increases 1.5 to 2 times, even if it is atypical. अब इसमें क्या क्या आते हैं? इसमें ductal hyperplasia आता है, fibroepithelial lesions like fibroadenoma, phyllodes that we were discussing, sclerosing adenosis, papillomas, radial scar. We are going to discuss all these lesions soon. Now proliferative lesions with atypia, मतलब उस proliferative lesion है और atypical changes अगर शुरू हो गए, then the risk of malignancy becomes 3 to 5 times than the proliferative lesions without atypia. So you can understand these lesions are very high risk lesions. अब इसमें क्या होता है? Lobular hyperplasia with atypical changes, atypical ductal hyperplasia. अगर ये आ गया, the risk of malignancy is 3 to 5 times, and we have to be extra cautious about these lesions. Friends, we will discuss about proliferative lesions with atypia, another high risk lesion, in some other program. In this program, we will be covering the non-proliferative lesions and proliferative lesions without atypia. Okay, because it requires जो proliferative lesions with atypia है, ये बहुत ही technical topic है. इसका जो management protocol है एकदम different है. We will not touch this topic as of now. In some other program down the lane, we will discuss about the in situ cancers and proliferative lesions with atypia. Okay, so now I request my co-speaker, Dr. Chani, to take over and explain about these lesions in detail to us.
Thank you, ma'am. So non-proliferative lesions, they are a heterogeneous group of disorders. A lot of non-proliferative benign disorders are clubbed under this umbrella. They are one of the most common benign breast disorders, usually seen in 20 to 30 years of age. They are not associated with cellular proliferation. They are caused by abnormal response of breast tissues to fluctuating ovarian hormones. Clinically, they'll present as irregular nodularity, which we also call lumpy bumpy. with or without tenderness, and occasionally they can be associated with discharge. These lesions, as ma'am has explained earlier, are not associated with increased risk of cancer. This is a typical gross of a fibrocystic lesion, which is one of the most common non-proliferative entity which we encounter. In this gross picture, we can see there are numerous cystic spaces. These are called blue dome cysts because they have a bluish tinge, and these cysts are surrounded by whitish tissue, which we all can appreciate. This is the fibrous tissue or fibrosis. So this is a typical fibrocystic lesion. On microscopy, these are characterized by three main alterations. First is adenosis, which is increased number of SNI per lobule. If we see the photomicrograph, we can see small round spaces. These are the SNI and they are increased in number. The second important feature is fibrosis in stroma. All the intervening pink area which we can see in the photomicrograph, all this is fibrosis. And third important feature is the cyst formation, which is cystically dilated ducts or lobules. In the photomicrograph, we can see numerous cystic spaces. And in the center, the cystic spaces are lined by eosinophilic cells. This is the apocrine metaplasia. Apocrine metaplasia and columnar cell change can also be seen. Some other non-proliferative lesions, an important one includes a lactating adenoma. It is not a true tumor. It is actually an extreme manifestation of pregnancy-induced secretory changes. Although the name is lactating adenoma, but it is more frequently encountered in the third trimester. And on histology, we can see they are hyperplastic secretory lobules, as we can see in the photomicrograph also.
So the importance of these lesions is like any palpable symptomatic abnormality or maybe an incident loma, because nowadays screening is very common. So any incident loma, if detected, it is a major cause of concern to the patient. No matter how hard we explain to the patient that there is no risk of malignancy, we try to assure the patient. Sometimes we also have to resolve the symptom, especially if it's a palpable abnormality, through guided aspiration, through painkillers, some lifestyle modification we ask them to do in the form of we try to restrict some alcohol, nicotine, and all, and anti-estrogenic medicines. In selective cases, we have to resort to surgery. So the importance of these lesions is that though there is no increased risk of cancer, but symptomatic treatment is must for these patients. Otherwise, they will always be under anxiety if the pain persists, if the palpable abnormality persists, that we have to take care. Now, proliferative breast lesions. These are often detected as a mammographic densities on screening mammography, or they are presented as a palpable breast lumps by the patient. They're considered as a predictors of risk for development of breast carcinoma and there are two types, without atypia and with atypia. So proliferative breast disease, they have an increased risk of developing breast cancer compared to the normal breast tissue. There are various types of without atypia, epithelial hyperplasia, sclerosing adenosis, papilloma, complex sclerosing lesions. अभी हम इनके बारे में डिटेल में डिस्कशन करेंगे. And with atypia like atypical ductal hyperplasia and atypical lobular hyperplasia. अब इसकी significance क्या है? As अभी हमने डिस्कस किया, if there is a proliferative disease without atypia, then the relative risk compared to the general population is 1.5 to 2 times of developing breast cancer, and the absolute lifetime risk is 5 to 10% above the risk for that age in the general population. उसकी एज के हिसाब से जो जनरल पॉपुलेशन का कैंसर रिस्क होगा, इन पेशेंट्स का कैंसर डेवलपमेंट रिस्क 5 to 7% हाई होगा, और अगर वो विद एटिपिकल चेंजेस हुए तो इनका रिलेटिव रिस्क 4 to 5 होगा, और जो absolute lifetime risk of developing cancer is 13 to 17% higher than the general population for the same age. So it's not like though they are clinically benign, so like we say okay, there is no risk of malignancy. They have certain amount of increased risk of malignancy compared to general population for that same age, which is high as the atypical features increase. So now I again request Dr. Chani to explain these images and these disorders to us.
First one is usual ductal hyperplasia. In usual ductal hyperplasia, there is increased number of both luminal and myoepithelial cells. The cells fill and distend the ducts and lobules. We can see the representative diagram over here. The duct is filled with cells, and the lumen can be irregular, and the remaining lumen is seen at the periphery. The same is depicted in the photomicrograph downstairs, in which we can see the duct filled with cellular proliferation, and there are irregular spaces at the periphery. Next is sclerosing adenosis. Sclerosing adenosis is characterized by increased SNI with lobular fibrosis. There is swirling lobulocentric pattern. Now, sometimes these can be associated with atypical epithelial proliferations and carcinoma in situ. But if there is no associated atypia or any in situ lesion, then the diagnosis of sclerosing adenosis is not an indication for surgical excision. Intraductal papillomas, these are lesions that grow within a dilated ducts with multiple branching fibrovascular cores. So intraductal papillomas can be of large duct papilloma and a small duct papilloma. The large duct papilloma arises from a lactiferous sinus. It is usually solitary and presents as bloody or serous nipple discharge. Small duct papilloma involves the deeper duct system. They are usually multiple, small palpable masses or some densities, and sometimes only as calcifications in mammograms. This is a photograph of a classical intraductal papilloma. There's a dilated duct, and within the duct, papillary fronts can be seen with central fibrovascular core, and they are lined by epithelial and myoepithelial cells. This is a case of multiple intraductal papillomas. Usually, if more than 5 ducts are involved, we call it as multiple intraductal papillomas, where multiple ducts are showing papillary proliferations. A very interesting lesion is the radial scar or complex sclerosing lesion. Scar is a misnomer because it is not related to any past history or past history of injury or surgery. It has a stellate or star-like configuration, which is sclerotic center and radiating corona of ducts and lobules around the center, as we can see in the photomicrograph also. Now, these ducts, they can show changes like usual ductal hyperplasia, sclerosing adenosis, apocrine metaplasia, and cyst. This lesion is significant because it closely mimics an invasive carcinoma mammographically, grossly, and sometimes even histologically. It can mimic a malignancy.
And one very interesting aspect of these proliferative lesions is the gynecomastia. This problem is not that it happens only, the proliferative lesions happens only in females. It may happen in males also, and when it happens in male, it presents as male breast enlargement or gynecomastia. It is the only benign lesion which occurs in male. Okay, why it happens? Because there is an imbalance of estrogen and androgens. We know estrogen stimulates breast tissue, androgen they counteract the estrogenic effect, and whenever this imbalance occurs, then in male the most common manifestation is the male breast enlargement. It happens most commonly during adolescent age, like around 13 to 25 years of age, when the male sex hormones are gradually increasing while the estrogen is not that much suppressed. And then in the elderly phase, when the male sex hormones are gradually decreasing, and so the relatively estrogen hormones they come up, then the drugs hoti hain like alcohol, marijuana, heroin, antiretroviral therapy, anabolic steroids. Tumors होते हैं Leydig cell or Sertoli cell tumor which secrete the female sex hormones, liver cirrhosis and other disorders. They also may cause this problem. This is a matter of clinical importance. Therefore, we just put in here to understand that this male breast enlargement is also a type of proliferative lesions without atypia. So these are usually a cosmetic problem. Once enlarged more than grade 2, then most of them require surgical excision in the form of cosmetic surgery. So now comes the breast stromal tumors. These tumors are very interesting because it includes fibroadenoma and Phyllodes tumor. Fibroadenoma is something which we really encounter in a day-to-day practice. Okay, so what is the fibroadenoma? It is the most common benign breast lump. These are the very discrete masses in young females. These are not the pathologies, but the aberration in normal development in involution or the product of hyperplastic process rather than true neoplasm. The incidence is 7 to 13% in general population. 50% of all breast biopsies. Rate rises to more than 75% in female under 20 years of age. So most of the patient in which we do breast biopsy, 50 to 75% we come across fibroadenomas only. Why they are caused? Usually they occur during menarche, 15 to 25 years of age, a time at which lobular structures are added to the ductular system of the breast. Before that, they are in the quiescent phase. And now, with the surge of estrogen and progesterone, they started proliferating. Though we don't know the exact etiology still, but it is being presumed that there is a hypersensitivity of the breast tissues to the estrogen. So estrogen is something which is the culprit. It grows during pregnancies and shrinks after menopause. Two-thirds of them have found to have mutation in MDM12 gene. So it, there is a genetic disorder which is very commonly found, though we routinely don't assess the patient with this genetic testing. But in researches, it has been found that two-thirds of them have mutation in MDM12 gene. So that is the reason that not all patients, not all girls, they develop fibroadenoma. We know two types of stroma we discussed about, interlobular and intralobular. And this diagram already we have discussed. So I request Chani to take over again and tell in detail about the pathological aspect of these tumors.
As discussed earlier, these tumors, they arise from intralobular stroma, a stroma entrapped within the lobule. The common ones are fibroadenoma and phyllodes tumor. Both of these are biphasic tumors, and they also have a non-neoplastic. They have a stroma as well as a non-neoplastic epithelial component, and mutations in MET12 gene is found. We commonly encounter the usual or adult type of fibroadenoma. Grossly, they are well circumscribed tumors, often 3 to 4 centimeters. Rarely, they can grow up to 10 centimeters. Cut surface bulges above the surrounding tissue. It's firm and grayish white, as we can see in the photo, in color and glistening. Sometimes slit-like spaces are seen. WHO criteria for diagnosing a fibroadenoma, it should be a circumscribed biphasic tumor. The histological pattern can be intracanalicular or pericanalicular, and importantly, there should be no stromal overgrowth, no stromal atypia or mitotic activity. Based on the pattern, we can see two patterns are there in the photomicrographs, intracanalicular pattern and pericanalicular pattern. The stroma has overgrown and compressed the ducts into elongated slit-like spaces. And in the pericanalicular pattern, the ducts are able to maintain their lumen and the stroma is growing around them. Variant is a juvenile or giant fibroadenoma. Usually they are larger than 5 centimeters and 4% of cases are there. They are rapidly growing masses with breast asymmetry, and we usually find them in young females and adolescents. Histologically, they have more cellular stroma and they show the perilobular pattern and gynecomasia-like epithelial hyperplasia. So what is gynecomasia-like epithelial hyperplasia? That is useful diagnostic tool for pathologists. If we see the photomicrographs here, the upper one shows a cellular stroma, and in the lower photomicrograph, we can see the ducts are lined by 3 layers of ductal epithelium. So this 3-layered epithelium is a classical feature of gynecomasia, and similar hyperplasia we find in juvenile fibroadenomas. So this is an important feature to differentiate from differential diagnosis of phyllodes tumor. And these juvenile fibroadenomas, like others, are benign and there is no risk of malignancy. Next one. Some other variants of fibroadenomas are myxoid fibroadenoma. It is similar in structure, but as the name suggests, with prominent myxoid stromal change, which is composed of abundant pale blue-gray extracellular matrix. We can see in the upper photomicrograph, the matrix is pale blue. This is a myxoid stroma. Second one is a complex fibroadenoma. Now, in complex fibroadenoma, either one of the 4 features are found to be associated with the fibroadenoma. These features include cyst more than 3 mm, or sclerosing adenosis, or epithelial microcalcifications, or papillary apocrine metaplasia. Any one of these features are found, then it is labeled as complex fibroadenoma, and they are supposed to carry 2.3 times risk of developing heart. Other important stromal or fibroepithelial tumor is the phyllodes tumor. Phyllodes is Greek for leaf-like, because if we see the gross of a typical phyllodes, there are large bulbous leaf-like projections in the clefts or cystic spaces. We can see in this photograph also there is a cystic space, and inside it there is a protrusion of a leaf-like bulbous projection. This is a classical feature of phylloids. They are also derived from infralobular stroma, and majority have MEB12 mutation. Now, malignant phylloids, they usually are poorly circumscribed and they are locally invasive with infiltrative borders. Now, if we see microscopy growth pattern, they typically phylloids show an exaggerated intracanalicular growth pattern with important as leaf-like projections into the dilated lumens. If we see both the photomicrographs, on the left side is a fibroadenoma with intracanalicular pattern. Now on the right is a phylloids tumor, looks quite similar, but the difference is there is more stromal proliferation, and if you look closely, there is a leaf-like frond on the right side which is projecting into the cleft. So these fronds are very typical of phylloids and they are very useful in differentiating from an intracanalicular fibroadenoma. Other features are clarity, mitotic rate, nuclear pleomorphism, stromal overgrowth, and infiltrative borders. All these features are important for diagnosing phylloids tumor as well as grading them. Now, depending on appearance of the stromal component, phylloids tumors are divided into benign, borderline, and malignant. I'll not go into much detail because of the time constraints. Just a brief overview. The first photomicrograph is of a benign phylloid, second is borderline, is malignant. So in the benign one, we can see the stroma has a lower cellularity and a lot of epithelial structures in the form of clefts can be seen. In the borderline one, the cellularity has increased and the epithelial component has reduced. And in the malignant one, cellularity is more, there is more pleomorphism, as well as we can see this is the edge of the tumor and it can be seen infiltrating into the adipose tissue or the fat. These are fat spaces and tumor can be seen infiltrating into it.
Yeah. So with this information in mind, just picture of how these three types of tumors actually look like. So in the first picture is the fibroadenoma, the typical fibroadenoma that we usually see in our clinical practice. The second one is a 13-year-old female who presented with this huge breast lump. Apparently, it looks very fairy with dilated veins, stretched skin, and a huge size difference between the two breasts. The nipple is shifted down and all. But it came out to be a juvenile fibro. We treated this patient as a phyllodes tumor, but it came out as a juvenile fibroadenoma. So this is the typical juvenile fibroadenoma. And this huge breast lump, it's a phyllodes tumor. So this is how like we see such cases. So the two main questions that come out with any fibroadenoma is the breast cancer. Is it, what is the association of fibroadenoma and breast cancer? Does the fibroadenoma convert itself into the breast cancer in the long run? Or is it a marker of increased risk of breast cancer? So to answer one by one, can fibroadenoma turn malignant? Simple fibroadenomas, there is slightly increased risk, almost negligible. The risk of subsequent malignancy is higher in, and these are the red flag signs. In complex fibroadenomas, like if we are leaving a complex fibroadenoma, we are leaving a high chance of malignancy development in such ladies. A fibroadenoma in older women, because fibroadenoma usually starts or develops in younger patients. So if an older woman is developing a fibroadenoma like lesion, we cannot take it lightly. A fibroadenoma in a woman with a family history of breast carcinoma, because these ladies have a very high chances of developing cancer in younger ages. So even in younger patient with a very high risk history of familial breast cancer, every lump must be assessed with a high suspicion. Malignant transformation in epithelial component of breast cancer is exceedingly rare, 0.002%, 0.0125% is exceedingly rare. However, it is not negligible. It is not none. Like it doesn't happen. It can happen, though it is very rare. Cases are reported. So the important is there is a 1.3 to 2.1% increased risk of breast cancer in fibroadenomas compared to general population, and this elevated risk persists and unchanges with time. The risk of cancer increases with certain histological types of fibroadenomas. तो fibroadenomas के जो हमने इतने सारे types अभी study किए, तो उनमें से कुछ इंपॉर्टेंट फाइब्रोडिनोमास होते हैं, अगर कभी हमारी बायोप्सी रिपोर्ट में वो रिपोर्ट हो, देन देयर इज अ वेरी हाई रिस्क ऑफ डेवलपिंग कैंसर इन सच लाइक कॉम्प्लेक्स फाइब्रोडिनोमा. With complex fibroadenoma, there is a 3.1% increased relative risk of breast cancer. So please remember, complex fibroadenoma. Then proliferative changes in the breast tissue adjacent to fibroadenoma. So there is a fibroadenoma, but the surrounding tissue is very hyperplastic or proliferative. Then also the chances of developing malignancy, the relative risk is 3.88%. अब एक कॉम्प्लेक्स फाइब्रोडिनोमा है विद अ पॉजिटिव फैमिली हिस्ट्री, द रिलेटिव रिस्क इज 3.72%. सो फ्रेंड्स प्लीज सी, विद अ नॉर्मल apparently benign looking fibroadenoma, the risk is 1.3 to 2.1%. With certain histological changes, the risk increases around 2 times high. Sometimes it happens that we do find fibroadenoma, typical fibroadenoma, but we do get histological surprises. So there are studies which try to find out the percentage of cancerous tissues that have been detected in following the excision of fibroadenoma. So they found most of the cancers are of lobular cancers, lobular type, like 50% were lobular in situ cancer, 20% were infiltrating lobular cancer. तो most of the cancers were lobular, क्योंकि हमने पढ़ा था TDLU में ये बनता है टर्मिनल डक्टल लोबुलर यूनिट, इसलिए ज्यादातर लोबुलर कैंसर थे. 20% were DCIS, ductal carcinoma in situ, and 10% were invasive ductal carcinoma. तो ये चीज हमने समझी कि most of the cancer, if it arises, though it is very rare, it is a lobular type of cancer that arises, that is being found. Now what is the natural history? So इस पे भी बहुत सारा काम हुआ है. तो they try to find out the natural history. The thing is, with advancing age, it has been found the size either remain static or decreases with time. तो जो size, suppose like ऐसा देखा गया है कि young age में, adolescents में जो size था, अगर उसको ऑपरेट नहीं किया और उसको फॉलो किया with years, तो most of them they decrease in size. But if the size is more than 1 centimeter, it is very less chances that it will regress completely. Less than 1 centimeter, जितना छोटा होगा, suppose 0.4, 0.5, 0.7, it is very high chances कि वो वहां से खत्म हो जाएगा, regress कर जाएगा, हो सकता है कहीं और बन जाए. But if it is more than 1 centimeter, suppose 2 centimeter, 3 centimeter, then it is high chances it may not grow, but it will not completely regress on its own. ये हो सकता है लेटर ऑन आइदर इन्फेक्शन की वजह से या एक मेटाप्लास्टिक कैल्सिफिकेशन की वजह से वहां पे कैल्सिफिकेशन हो सकता है उस फाइब्रोडिनोमा का, which on mammography may present as a popcorn calcification, but the lump will still be palpable to the lady. So this may happen, like जिसको most of the fibroadenomas they remain quiescent like this. Sometimes it happens that some internal transformation happened to those lesions and they started increasing in size. So any patient when presents with a breast lump, how to manage such patient? Management starts with assessment. So we have triple assessment. First we take the history and physical examination, a thorough history and physical examination. जो अभी हम समझेंगे कि what are the important histories that we must elicit from a patient and how we should do a physical examination, clinical breast examination in such patient. Second is to verify and characterize the lump with the help of imaging, X-ray, ultrasound और MR mammography, and that we will discuss कि किस पेशेंट में एक्सरे कराना है, किस में अल्ट्रासाउंड कराना है, किस पेशेंट में MRI कराना है, and the preferably biopsy. Now come to history and physical exam. History and physical examination हमें help करता है to risk stratify the patient by identifying the known risk factor for breast cancer. So when we take the history, we ask for अच्छा घर में किसी और को तो कैंसर नहीं है, मम्मी को, मम्मी की फैमिली में something like. So we try to elicit the various high risk factors. उसकी एज पूछते हैं, पैरिटी बच्चे कितने हैं, ब्रेस्ट फीडिंग हुई कि नहीं हुई, कोई टोबैको, अल्कोहल, ओबेसिटी, इस तरह की कोई फीचर्स हैं कि नहीं है. उसकी एस्ट्रोजन विंडो हम आइडेंटिफाई करते हैं कि मेंस्ट्रुएशन कब शुरू हुआ, हार्मोन रिप्लेसमेंट थेरेपी तो नहीं ली पोस्ट मेनोपॉजल फेज में, ओरल कॉन्ट्रासेप्टिव पिल तो नहीं ले रही है, इनफर्टिलिटी का ट्रीटमेंट तो नहीं लिया. पर्सनल और फैमिली हिस्ट्री ऑफ कैंसर्स स्पेशली पूछते हैं, कोई ब्रेस्ट कैंसर का हिस्ट्री रहा हो, ओवेरियन कैंसर, पैनक्रियाटिक, जीआईटी स्पेशली कोलोन, प्रोस्टेट कैंसर, थायराइड कैंसर. तो ये चीजें हमें कि इस लम्प को हमें कितना सीरियसली लेना है. history of trauma, fever, local tenderness, pain, erythema, cyclical changes in size, ये चीजें हमें इंडिकेट करती कि पॉसिबली अगर इससे रिलेटेड है तो हो सकता है वी आर डीलिंग विद अ बिनाइन, टोटली बिनाइन लंप। और अगर हमें कोई हाई रिस्क फैमिली हिस्ट्री मिलती है तो हमारे रेट ऑफ ग्रोथ की आपने जब देखा तब से अभी तक कैसे बढ़ा हुआ है। सो देयर इज अ स्मॉल वीडियो just for out of interest to demonstrate how we should actually examine the patient in a busy OPD, how you should quickly examine a patient with a breast lump. So strip all the clothes from the patient. Just first examine with the hands on the side and ask the patient to lift the hand to see if there is any tethering, puckering. Then do a cupping of your hand, and with the palm and the tips of your finger palpate in a circular motion. Feel all the quadrants of the breast in a clockwise manner. Examine the normal side first. After examining the periphery, come to the center gradually and palpate the retroareolar part. See for any tenderness, see for any lumpiness that you can feel. Squeeze the nipple areolar complex to see if there is any visible nipple discharge. Now, any lesion we describe in terms of clock. This 12, 1, 3, 9, something like this. So we describe all the lesions in terms of clock so that we can share our information to the colleague in a consistent way. Now repeat the process on the affected side जहाँ patient ने complain की है. So always examine the normal side क्योंकि अभी हमने lump का क्या पढ़ा था, consistency different होनी चाहिए from the normal side, same area. अब जब लंप मिला तो हम उसका एरिया देखेंगे. लाइक दिस लंप इज एट 9 to 10 o'clock position, peri areolar. Okay, so it is very important to examine the axilla. So all the three, the anterior fold, posterior fold, medial and the lateral fold, same on the other side. And not to forget to palpate the supraclavicular lymph nodes and the infraclavicular lymph nodes. So in your busy OPD, with this thing, you can quickly screen out, examine any patient with a breast lump. Now, we have identified the lesion on clinical examination. We need to verify whether what I am feeling a lump is really a lump or not, and what are the various features of this lump. For this, we need imaging. And I request Rupali ma'am to now take over and tell us about the how we should do and what are the prerequisites and the other factors related to imaging.
Thank you, Sudhi. Thank you. So in the imaging part, we have three main modalities. To screen the breast, these are X-ray or what we call the mammography, ultrasound, MR mammography, but it is done in the selective cases only, in the high-risk cases with dense breast. In the breast implant, to obtain more information in already diagnosed breast cancer, and it is normally only to be advised by the specialist. So coming to the main modalities now, the sonomammogram or ultrasound breast. So this is the investigation of choice for a female under 35 years of age, and it's very safe in pregnant females or age, but below 35, this is the investigation of the choice. So the bilaterally full breast and axilla scanning is mandatory. The normal side is scanned first. It is not affected by the breast density. There is no radiation hazard, and it is safe in pregnancy. So the advantages of the ultrasound breast are in diagnostic and in intervention. It distinguishes solid from the cystic lesions, the malignant and suspicious from the benign lesions. The multicentric lesions with the exact size and location can be recorded. The exact dimension of the lesion can be recorded. It is useful in the follow-up measurements. The axillary lymph nodes, their sizes and characteristics can easily be seen. It is good for the interventional procedures. Guided core biopsies, guided aspiration, clip placements, the wire localization. But it is still not the ideal screening modality for breast cancers as such. This is because there is an inability to see the image as a whole at once. In ultrasound, the superficial lumps are more easily seen than the mammography. And in the mammography, it is a deep inside the breast. It is a more user-dependent technique. If it is not done carefully, there is high chance of missing the lesions. It is less sensitive in detecting the microcalcifications. So, coming to the X-ray mammography, this is ideal investigation of choice after 30 years in a non-pregnant female. The ultrasound is used as an adjunct to this mammography. The X-ray mammography advantages is able to detect the microcalcification. It has limitations also. Its sensitivity decreases with the increasing density of the breast. Nowadays, we have tomomammography, which is the multiple mammograms at different angle, and it is better sensitivity in the dense breast. Mammography may miss the lesions out of the view, and it has to be we as radiologists have to closely collaborate with the clinicians in case of the discordant findings. Now, this BIRADS imaging, breast imaging and reporting system, it was developed by ACR, and it aims to standardize the breast imaging terminology, the report organization and assessment. It is useful in interpreting the mammogram and ultrasound results. It provides a structured reporting classification system for mammography, ultrasound, and breast MR so that these results can communicate easily among the radiologists and clinicians clearly and consistently with a final assessment and specific management recommendation. So, BIRADS has six categories. Grade 0 is a category which needs additional imaging or prior examination. It's an incomplete study, so we categorize it BIRADS 0. It requires for the additional imaging and await the prior examination. BIRADS 1 and 2 are the BIRADS 1 is a normal breast. It's negative, it's a routine screening, and there is a 0% chances of developing breast cancer. BIRADS 2 comes for the benign lesions. The routine screening, it too has a 0% likely of the breast cancer, and it includes mainly the cysts, the normal small fibroadenomas, lipomas, hematoma. These are the things which are easily included in BIRAD 2. Then we come to the BIRADS 3. These are probably benign. They have less than 2% chances of developing a breast cancer. These include the complexes, atypical fibroadenomas, intraductal papillomas, and in management, the short-term follow-up is required 6 months or so for these BIRADS 3 lesions. BIRADS 4 is a suspicious lesion. In this suspicious, we have categorized it further into 4A, 4B, and 4C. From 2 to 10%, it comes under the category of 4A. From 10 to 50% comes under the category of 4B. There is a moderate suspicion for malignancy. 4C is highly suspicious, is more than 50%, less than 95%. It has all the criteria in a mammogram and ultrasound, speculated margin, posterior acoustic shadowing, microcalcifications. These all come under the category of BIRADS 4. BIRADS 5 is a highly suggestive of malignancy that more than 95% and the tissue diagnosis is 4 biopsies are indicated. BIRADS 6 is a biopsy proven is BIRADS 6. So, giving this short review, the mammography is not the ideal investigation always. In mammography, here we are seeing well-defined mass. This is ideally fibroadenoma, and this is a cyst in ultrasound, and this is we're seeing a well-defined mass in a mammogram. It can be a fibroadenoma. It can be a cyst also. So we have to combine it with an ultrasound to delineate what exactly the lesion is. So seeing into the ultrasound, what we see is an oval, well-defined capsulated mass, thin rim, no calcification, is more wider than taller, which is it has no posterior acoustic shadowing, and seeing ultrasound, and here is a cystic area. Both of them are seen as a solid mass on a mammogram. So mammogram alone is not the ideal choice. Mammogram plus ultrasound is more effective in delineating what the lesion exactly, the nature of the lesion is. So here we are seeing a fibroadenoma versus a phylloid, which is a common diagnostic dilemma. We see, say, a fibroadenoma is a well-defined oval structure. In phylloids, there is heterogeneity of the ecotexture. There is small cystic spaces, what we see in a mammogram more easily. Then there is a bit of lobulation, microlobulations that develop, while fibroadenoma is a very smooth lesion in ultrasound and a mammo. So a lesion more than 3 centimeter with mild microlobulations, heterogeneity of the ecotexture, and cystic lesions in the MR. These go more in favor of the phylloid tumor in compared to the fibroadenoma. In MR, also we can say the In MR, we have the type 1 to 3 curves, which are the enhancement kinetics in the MR after giving gadolinium. So this can further delineate the breast lesion. Thank you so much, Sudhi.
Yeah, thank you very much, ma'am. Thank you for elaborating such a topic very beautifully. But friends, please don't worry. We will have a dedicated session of Brendos on mammographies, X-ray, ultrasound with one of the renowned radiologists of the country. We are planning it in December, so please stay tuned with us, where we will discuss about how to read the mammography, interpret the mammography by the clinicians, and what are the do's, don'ts, and what are the various points that we must take into account while we interpret any mammography. So we will learn about mammography later on also. Here we provided a brief overview of how this benign breast lump actually we follow, and what are the basic criteria, when should we ask for ultrasound, when should we ask for X-ray mammography. Okay, now friends, now we now know that we have a breast lump. Imaging has shown that it is a lump. Now which lump is this? We have discussed so many lumps till now, you know. So friends, what happened earlier, all the breast lumps once diagnosed were usually have an excision biopsy, and after that we used to have an histological assessment. But in 1960s, FNAC come, the fine needle aspiration cytology. Since it was less invasive, it was preferred over doing excision biopsy. Replaced by the excision biopsy, it became popular. However, in mid 1990s came the ultrasound guided core needle biopsy, but it remained an alternative to FNAC. FNAC remained number one in the assessment of any lump. But we found that with FNAC there were so many restrictions. Sometimes we were not able to pick that much amount of cell to establish any clear cut diagnosis. Ultimately, we had to resort to biopsy again. Then came the current gold standard in diagnosing breast lump, that is the core needle biopsy. So this core needle biopsy, it provides an accurate diagnosis, as well as it provides considerable amount of tissue to perform immunohistochemistry if it comes out to be malignant. Reason, all the malignancies are not same. In many malignancy, we are planning and management changes according to the immunohistochemistry. So that's a different thing. We are not discussing it about it right now. So for any lump, now the gold standard is doing core needle biopsy. Okay. So different molecular types of cancers have different management. Now this is very interesting. Age-based approach to palpable breast lumps, because friends, as already discussed, the risk of malignancy increases with age. So the risk of malignancy, so any palpable breast lump at 60 years of age, we will have a different management approach compared to a palpable breast lump in early ages, suppose 15 years, 16 years. So we have a different management approach. So this is very important to understand. Since the risk of cancer increases with age, below certain age, not all breast lumps require full triple assessment, as it may increase the cost and cause some psychological implication. Pain has a great psychological implication. If we ask for core biopsy, if we ask for FNAC for each and every lump in an early adolescent patient, so these patients are very sensitive. It has a huge psychological implication on them. So we have categorized them into the adolescents under 25 years of age and adults more than 25 years of age. Under 25 years of age, the risk of cancer is only 0.1 per 1 lakh population. So over investigation is not required. Fibroadenoma in this age group is most common, more than 95%. Fibroadenoma is most common, as already told. Juvenile fibroadenoma is more than 5 centimeters. They are the definitive indication for surgical indication. So a large breast lump is a definitive indication. Other than this, may have cyst, we may have hematomas, fat necrosis, inflammatory breast conditions, lymphoma, sarcoma. Extremely rare, but it could be a possibility. So, how to identify which patient require intervention, which patient doesn't require that close intervention or prompt intervention? Just inquire about if there is any significant family history of breast cancer under 40 years. Breast cancer, first you inquire about breast cancer, and especially then whether that cancer happened after 40 years or below 40 years, because young age breast cancer, very high likelihood of familial breast cancer or genetic breast cancer. Now see whether the lump is irregular, firm too hard, or it is rubbery in consistency like a typical fibroadenoma. Look for skin erythema or tethering. If there is any associated bloody nipple discharge or nipple retraction, or it is a rapidly enlarging mass. So because these are the red flags, and if any mass lump is associated with these features, it is always advisable to go for core biopsy and intervene accordingly. Now, how to manage these patients? Typical benign features on clinical and radiological examination, no biopsy required, only follow up the patient. Follow up the patient, reassure the patient that see, you don't have any features suggestive of malignancy, the lump looks small, the lump looks benign. Now you have two options. Always give option to the patient that if it is more than 1 centimeter, it may not regress, it may remain palpable, but it may not harm you. So if you are comfortable, keep up under follow-up, show to us, we'll do clinical breast examination, we'll do imaging 3 to 6 monthly. And if there is any features of increase in size or change in nature or your mind changes, then we may anytime operate. So we operate the we follow the such patient with the breast self-examination monthly basis after the menstrual cycle, clinical breast examination 3 to 6 monthly, and imaging 6 to 12 monthly, depending upon the patient's circumstances, the emotional instability that she has. However, we do some surgical intervention whenever we see that there is a tumor growth, and we must always respect patient desire. The patient must be mentally fit. She should be happy. She should be satisfied. So if the patient say, I don't want to keep even this benign lump, respect her desire and operate. Do surgical intervention, just excise it. Now, if the patient is above 25 years of age, the risk of cancer increases in this age. So, still, the most common cause of lump in such patient is fibroadenoma. There could be now inflammatory lesions, cyst, hematomas, and cancer. Cancer is now relatively common, though it is still much less common than fibroadenoma or other benign breast lump, but it is much more common compared to the patients below 25 years of age. These patients require full triple assessment. It is mandatory. The safest approach is to remove all palpable breast lumps in patients above 30 years, or if the patient is not willing, not mentally prepared for surgery, she doesn't have resources to get herself operated. These unoperated lesions must have a close follow-up. You don't leave this lesion, you go, you don't have malignancy, you never come. No, you always follow these patients closely. So again, the breast follow-up is monthly breast self-examination after menstrual cycle, then clinical breast examination 3 to 6 monthly, and imaging 6 to 12 monthly, or in between, if the patient has any new complaint, then in between also we may do clinical breast examination and we may repeat the imaging and compare it with the previous images. Now, surgical intervention is required whenever the tumor is at the presentation is large or it is enlarging on interval follow-up. It has suspicious features or the patient desires. If the patient desires, always go ahead. But before that, you always have a core biopsy to understand the nature of that lesion. So this is the summary of what we have discussed till now. So anytime you can go through it and refresh your understanding about this treatment algorithm. So majority they maybe manage. Reassurance is the most important aspect of treatment. So majority they get well with the reassurance only, no active treatment. If they are willing, and only follow up is required. Natural course may, as already told, they shrink but they don't disappear. Especially if the lump size is more than 1 or 2 centimeters, then they don't disappear. They may shrink with time, and sometimes they become calcified. And in many patients, in my clinical practice, what I have seen, if the lesion become calcified, sometimes it irritates the nerves, and the patient often complain of pain in that area. And ultimately, we have to excise that lesion. So surgical intervention is required when the size is large at the time of presentation, or it enlarges during follow-up, or it compresses the adjacent normal breast tissue, and or the patient desires. Now, what are the various modalities? Lumpectomies, excision biopsy, we all know. But do we know that there are some newer modalities that are coming up, like the US guided vacuum assisted breast biopsy, cryoablation, in which the cryoprobe freezes and destroys the fibroadenoma like this. We are going to discuss about. I am going to demonstrate how these procedures actually happens, especially the US WAB. Friends, this is the typical surgery that usually we used to do. Open breast lump excision. This is how we used to remove the tumor. But please have a note of the scar. No matter how hairline scar you give, the scar will remain be visible to some extent in such patients. Gone are the case. Now, this phase, this era is gradually and gradually being replaced by these scarless surgeries. So, friends, this lady has a lump in the upper inner quadrant, and she is being managed by this stitch, by this is small incision. This is not in fact incision, this was a stab through which that whole lump, the 3 centimeter lump, was excised. This lump was very deep inside the breast, and you can see that this patient has a very huge breast. Like, these are large bulky breast, and in that breast a 2 centimeter lesion deep inside the breast, it's very difficult to, and that too far away from the nipple areola complex, just in the middle of the breast. So anyhow, like, either we have to go through the periareolar approach to reach there under general anesthesia, or we have to make a direct incision over the lump to get access to the lump under local anesthesia. But we did it under local anesthesia through this areolar approach, and we removed that lump successfully and completely. Similarly, this lady has a multiple lumps in different quadrants of the breast. These were all apparently benign breast lumps, and we removed all the 3 lumps with this single incision, this small stitch that we see here. Same with this patient. This patient has a lump in the upper inner quadrant left breast, and we removed this lump with this small hole. So there's a demonstration. These surgeries were done through ultrasound guided vacuum assisted breast biopsy. So this is the very new technique that is available now in our city, in Meerut also, and we are doing it. So what we do it under local anesthesia most of the time, because the most limiting factor of this technique is the cost. So we cut down the cost by doing it under local anesthesia, and because we don't retract, we just anesthetize that area, and after the patient confirms that the area is anesthetized, we just put in our probe and take the lump, cut and suck, and this is how we do. This is the local infiltration, some local massage, and this is the stab that we give. That's it. This is the probe. This suction attached to it. Through ultrasound, we localize the lesion, we put a probe into it. The tumor is out through this hole. This is the tumor. These are the tumor tissues, and this is the stitch. And this is a wonderful technique for females, especially young females, because these benign lumps, though may cause anxiety, but giving a unsightly scar while removing the benign breast lump is not a good idea. So this is very promising technique. However, the most limiting factor of this technique is the cost, and maybe with more and more advancement, more and more patient opting for this, the cost will come down, that we are hoping. So let's see. This technique is very good for small lesions, especially less than 2 centimeters, for multiple scattered lesions, deep lesions, and non-palpable lesions. The one with very huge breast and a non-palpable lesion detected on screening, and the patient desires कि नहीं आप इसको निकालो, or we feel that there may be some features of malignancy. So in spite of going deep into that, just put your probe and take it out. For dense fibroadenotic breast, because in fibroadenotic breast, wherever you feel, you always feel यार ये भी तो बड़ा firm और hard सा tissue है, हो सकता है यहाँ पे भी कोई गांठ हो, and we tend to excise more tissue. Whereas when we do it ultrasound guided, we know okay, this much is the tissue, this much is the lump, and this much we have to excise, and we confirm it intraoperatively through the ultrasound, क्योंकि ultrasound में दिख जाता है कि कितना tissue रह गया, कितना नहीं रह गया. It is a very good modality. So it is a sort of a minimally invasive procedure. It's a very promising procedure, except for because of cost constraint, many patients are not able to afford it. but we are trying hard to make it patient friendly and within their limit. So, but conventional excision biopsy, we all know it is a low cost because no extra instruments required for that. It is good for large tumor. This is also a limitation of US web. The small tumors के लिए तो अच्छा है, but for large tumor, 4 centimeter, 5 centimeter, it may not be that effective in removing the tumor. Now the last is the cryoablation. Already told, I haven't used this technique till now, but what I have heard about it, it freezes the fibroadenoma tissue inside, and gradually it atrophies and resolves. So before that, you must have a core biopsy. A core biopsy होनी जरूरी है to establish the diagnosis that it is truly a fibroadenoma and not something else. But still, because इसमें we don't have that much of tissue, so the histological diagnosis is usually not that much. There are chances that we miss out the malignancy in such lesions. So this is one of the drawback, but maybe with time हमारे पास बहुत अच्छा एक्सपीरियंस होगा इस तरह की मोडालिटी में, where we don't take out the lump and we just freeze it inside the body. So the take-home message is benign breast lump. It is found in it constitutes more than 90% of attendance in any breast clinic. The aim is to screen out potentially malignant lesions for early management. The pros and cons of conservative and surgical procedures must be discussed with the patient. So, even if we diagnose it is a benign breast lump, the pros and cons of conservative as well as surgical procedures, just discuss with the patient and let the patient take the order. Let the patient decide what she wants because the patient choice is a priority. Conservative therapy is not an unrealistic aim. However, with surgery, we can completely cure the patient with complete pathological diagnosis for further management because mental health is equally important than physical health. And these are the references with which we take the help of. And with this, I would like to thank you all for your patient hearing. And we are now ready to take on any questions from the floor.
Wonderful presentation, Dr. Sudhi. You
Thank you.
have presented everything starting from the normal anatomy of breast up to different benign lesions in a very simplified way. And you truly said that most commonly we come across cases of fibroadenoma breast. And if any other lesion which is uncommonly seen by us, usually, so we try to refer the patients to breast surgeon of our city.
Thank you, ma'am. Thank you very much.
Yeah, and we came to know from Dr. Rupali and Dr. Chani also about pathological and radiological findings. And you explained about breast examination. So, but I also stress that we should also promote our patients for self-breast examination on a regular basis.
Yes, certainly, ma'am. And as a breast surgeon, I often try to we train the patients whosoever come to our interaction, like how to do breast self examination, other thing. Maybe on a community level, we'll try to do more such activities so that more and more females are trained into it.
Yeah. Now we would love to hear from our guest faculty, Dr. Ramya.
Hi, ma'am. That was a very elaborate and wonderful presentation on benign breast disease. I just have a few things to add. Like we all keep telling patients, like whenever they ask, why do I have this fibroadenoma? Why do I have this fibrocystic disease? We tend to tell them it's because of hypersensitivity of the breast to hormones. So, isn't it very counterintuitive that a postmenopausal lady should start developing fibrocystic disease? Like when the hormones are actually going down, that is when we are telling that there is adenosis, which is proliferation of SNI, which is hormone dependent. So, when I was actually looking into the pathophysiology, how the fibrocystic disease start, so it's actually not the hypersensitivity of the breast to circulating estrogens as much as it's actually some mutations, as you mentioned, MED12 happening within the breast tissue, which actually activates local within certain area of the breast. There are sulfatases and aromatases. So as the person ages, we know that the breast glandular tissue is replaced by fat. There is a local aromatase that is activated. So sulfatases and aromatases increase the concentration of sulfates and the products of estrogen within that area of the breast, and those cause proliferation of breast tissue. So that's the reason why only certain areas of the breast develop this disease. So if this is multifocal, of course, it happens that way. So the circulating hormones are normal, but because of local mutations, there is increase in these enzymes. This actually I read from a very elaborate paper that I would love to share that paper soon with you. Maybe you can circulate with others. So they have actually developed organoids of breast tissue, and then that's how they and some of these have been studied in detail. And one more thing is how we can differentiate radial scar from malignancy on mammography. So we know that radial scar also has speculated appearance, and mammography also has a speculated appearance, but the central lesion is not there within the in a radial scar. I mean, but there's probably a lesion. If we look at the tomosynthesis and scroll this way that way, probably will not be able to see a lesion. Then of course, another thing is we tend to patients tend to think that the fibroadenoma may turn into malignancy. So whenever we're saying that the risk for patients with proliferative lesions for malignancy development is higher, they tend to think that the fibroadenoma may turn into malignancy. It is not so. The factors that are contributing for formation of fibroadenoma may contribute for formation of malignancy later. So the fibroadenoma itself may not turn into malignancy, but that patient's propensity to develop a malignancy is more because everything, whatever we speak in the breast, is hormone dependent. So that's the reason why they have slightly higher tendency to develop malignancy, not that these lesions turn into malignancy. So sclerosing adenosis itself may not turn into malignancy, but the reason why the patient is having sclerosing adenosis could also be the reason why they can develop a malignancy. So other thing I think we have to stress that patients should start doing self breast examination in the 5th to 10th day after their periods, because otherwise breast can feel very lumpy and they start noticing all sorts of things. And we all, I'm sure we all are educating them to not pinch the breast like this, where everything starts looking like a lump, and just gently roll. And I think one more important thing is granulomatous mastitis. We all keep seeing a lot of these patients and we don't know the head and tail of it. And I think we can have a separate session to discuss granulomatous mastitis, because there's so much confusion and what to do, what not to do about it. I think these are the few things. And
इसमें
yes,
Adam
ma'am.
you put some very important points. The thing is कि you put about there is that we have already discussed in our slides. Actually, fibroadenoma and breast cancer association. So there are two things. There are two questions whether the fibroadenoma really turns into malignant lesion, or the factors which leads to fibroadenoma leads to malignancy also, like hyperestrogenism. So first of all, this hyperestrogenism, there are two factors. First of all is the absolute increase in the circulating estrogen hormone, and secondly is the hypersensitivity of the existing receptors to the same level of estrogen hormones. So the problem, what happens in such patients, because not all patients have the same, so it is actually not a single thing, it is a multifactorial. The lifestyle, the genetic factors, estrogen exposure, and many other things, they interplay and they form a situation where either a fibroadenoma, there are reported cases, so one cannot say like it have never happens. It has happened, and we have seen in our own patients that a fibroadenoma remained quiescent for for many years, and suddenly it is the same lesion started growing. So in our own clinical practice, we have encountered such cases. So we always keep the possibility of like we all never, as already we
In
have
case
never keep
ones like complex fibroadenomas.
not only complex, even apparently, because most of the time these lesions are not that much worked up because core biopsy is not frequently done till now at many places. Secondly, you are very right. This factor is also very important because this hyperestrogenism is causing the proliferation of the breast tissues, and this is also a proliferative breast lesion. So this hyperestrogenism, and this is the hypersensitivity of the estrogen and not the hyperestrogenism as such. Okay, so because the breast tissue is very hypersensitive, therefore I have mentioned that any patient with fibroadenoma, there is a certain increased risk of malignancy compared to the general population. It is not like, so because of the same factor, because these tissues are very, very sensitive to circulating amount of estrogen. You know? So I think I have made my point. We have already discussed about it.
So,
Ki,
what I was saying, ma'am, is that some patients, like over the years, they just tend to follow the size of their fibroadenoma. So they just think that ultrasound में fibroadenoma का size नहीं बढ़ रहा है, तो I'll stop screening. ऐसा नहीं है. They still should continue not to look at that fibroadenoma, but just in case, if because they have a higher chance to develop.
And also some other lesion, because breast tissue तो वो
Yes,
पूरे
yes,
certain part में fibroadenoma बन गए, किसी
yes,
और पार्ट में हो सकता है ब्रेस्ट, हो सकता है उसी के एडजेसेंट साइड पे कैंसर डेवलपमेंट शुरू हो जाए और वो
yes,
बढ़ने लगे और उसको लगे कि ये तो फाइब्रोएडेनोमा ही बढ़ गया,
yeah.
ऐसा भी पॉसिबिलिटी. सो विद इंक्रीजिंग एज जो हमारे क्राइटेरिया है मैमोग्राफी स्क्रीनिंग के, दैट लेडी मस्ट ऑलवेज ऑलरेडी इफ शी हैज अ लम्प, then such patient, even if we are not operating, we always closely monitor such patients and they must be followed. And regarding granulomatous mastitis, I truly like appreciate your concern, and I am also that much concerned. And luckily, we had recently managed a case like that. And this we are planning in December. We are going to have a dedicated mammography session in Brandos, December breast meet. And before that, in October, we had two plans, either mastalgia or granulomatous mastitis. So maybe idiopathic granulomatous mastitis we will try to put there, and we'll try to resolve so many of our issues. So you gave me a very good idea, and now my mind is prepared. Like we will discuss about IgM that next time. Thank you very much. Huh?
Thank you, ma'am.
Okay, so actually there are certain important questions like I received from few of my participants in my personal chat. So first of all, ma'am, like as a gynecologist, Mona and Archana ma'am, if you can help me, what is your perspective? Suppose any patient with breast lump come to you, how do you manage? As a breast surgeon, just want to understand a gynecologist perspective.
Thank you so much, Sudhi. Thank you so much for inviting. And first of all, I would like to congratulate you for organizing such a unique program and for such a wonderful talk. Dr. Sudhi, Dr. Chani, and Dr. Rupali, all of you were excellent.
Thank you.
And when the question arises, how do we approach to a case of breast lump? Once a patient comes to us with a breast lump, just we have to see what is the age. Age is very important. Suppose according to the recent practical bulletin of ACOG guidelines, we see if the woman's age is less than 30 years, we can see for 1 to 2 menstrual cycles. Apart from if there is not a very high suspicion of malignancy, suppose you are clinically having a high suspicion of malignancy, that is another thing. Otherwise, you will follow up after 1 to 2 cycles. If she is having the same lump, you will go for ultrasonography, and in the ultrasonography, whatever the Byrate's scoring says, if it is 4 and 5, then we will go for biopsy, and if it is 1, 2, and 3, accordingly we will manage accordingly. And if it is her age is more than 30 years, we will straightforward go for investigating the patient and managing her.
So basically, in young patient, you tend to follow those patients more, like with
Yes.
earlier with the conservative, and later on you investigate.
Later on, yeah.
Okay, and
I have one question, Dr. Sudhi.
yes, ma'am.
What is the cutoff size of fibroadenoma for surgical management?
Ma'am, there is no cutoff size. There is no cutoff criteria. So what the important thing is, there are two scenarios. In first case, the patient presents with a palpable breast lump. It could be anything, because like size is relative to breast, and size is also relative to the depth of the tumor. So if it is a large type, in a large breast, even a large tumor, if it is deeply seated, we may not palpate, no matter how big it is, like 3 centimeter, 5 centimeter. In a small breast, superficial lesion, even if it is 1 centimeter, it is palpable. So the important thing is whether the patient is symptomatic or not symptomatic. So patient presents with a palpable breast lump. If she presents to us, it is implied that the patient is concerned about that lump. And every time with her fingers, if she palpates, she becomes more worried about that lump. Second scenario is the patient presents with an impalpable breast lump detected on screening. So the lesion is not palpable. Okay. So the management approach then comes to us is what to do. So as already told, we first try to find out whether we are dealing with a malignant lesion or a non-malignant lesion. Thumb of rule is always consider all the breast lesion malignant until unless proved otherwise, or high risk lesion. So if now we are sure that the patient doesn't have any features of malignancy, it is a clear cut benign lesion, age is suggestive, ट्यूमर के फीचर्स सजेस्टिव हैं, उसकी FNA कोर बायोप्सी सभी चीजें सजेस्टिव है, Then we discuss with the patient. Okay, what do you want? It looks like apparently benign. So do you want to follow or do you want to get it excised? So if the patient says no, no, I'm okay with this, we say okay, you follow. There is no urgency from our side. In any case, you feel like it should be excised, let us know. In case patients say no, I'm worried, you please take it out. Then we excise the lesion and send it for final histopathology. So
Ma'am, I'll
this
add, with your permission, I'll add some things to this. So, certain group of guidelines start with the size of 2.5 and 3. But more than that, I think the ultrasound appearance of the lesion is very important. So, one practical way of doing, if there are gentle lobulation in 3, I think it is safe to consider them fibroadenomas. And if they're proven to be ones, we may just follow them up. Or if the fibroadenoma is solitary, and having more than 3 lobulations, or if there are microlobulations, even though it is freely mobile, it has to be investigated well, because especially in young women, since the triple negative variety of breast cancers don't have time to form the fibrotic reaction to give that free mobility, I mean to give the appearance of a malignancy. Freely mobile solitary lumps with more than 3 lobulations and with microlobulations have to be looked at very, very carefully. And in the case where the patient has multiple fibroadenomas, if they are less than a centimeter, I think we can just follow them up. But we have to be careful, very even in these patients, because I have seen 2 patients in my practice that they have multiple fibroadenomas, but our radiologist raised a red flag saying one of the lesions is having more lobulations and they have some borders are not looking convincing. So when we biopsied it, it actually turned out to be a malignancy. So, in any which way, I mean, I think radiologist gut feeling and your own judgment and just following them up carefully is very important. I think having radiologists like Dr. Rupali actually helps surgeons to get even more, I think, confidence to follow them or to excise them.
Yeah, so if I can summarize what Ramya told in a very few points, that not all breast lumps in the same patient in the same breast are same.
Yes.
So whenever as a breast surgeon we see or screen out any patient to evaluate the breast, we see all the lumps individually. So there are possibility patient has multiple benign breast lump. In between that, we may have a foci or a focus of malignancy also. So each lump or every lump is even in the same patient, same breast, same time. We are evaluating. Not all breast lumps are same. Evaluate each lump separately and decide which you want to biopsy, which you want to leave.
Yes, I think the radiologists are very, very helpful in this regard. So they are able to fish out that those lesions which they just say that this doesn't look convincing, and that, I mean, technically they may not fit it into any one thing, but they have the feeling inside, having looked at so many, that they suggest us to follow these lesions.
So the thing is important thing. So now my another question, like Chani, I would like you to please answer. You told about intracanalicular, pericanalicular myxoid form. Complex fibroadenoma, we understand, like it is a high risk and radial scar, high risk of malignancy. What is the utility of these different pericanalicular, intracanalicular, myxoid type of fibroadenoma? Why, as a surgeon, what is uh, the importance to me as a surgeon knowing about these type of different type of histological variants? So, ma'am, all to all the gynecologists, if I can ask a question with your permission, I've seen many breast lumps, those who presented to our clinical practice, they were taking anti-estrogen, danazol or Novex or tamoxifen, something like this. So, what is your experience? Like, is it being recommended somewhere to dissolve these lumps? Those are palpable, in palpable breast lumps also. They were being given these type of medicines. So, what is the experience? Is it recommended in some of the forum or what?
I think I would like to mention that there is an entity lobular carcinoma in situ,
Yes.
Mhm.
and in this lobular carcinoma in situ, risk reduction treatment is recommended, in which tamoxifen is given. Tamoxifen and raloxifene is given.
Okay, but that is this is called chemo prevention, and we give very high risk lesion. But for fibroadenoma also, so if it is not recommended, what I suggest as a breast surgeon, these lesions they don't go with the a discrete breast lump will not dissolve. If it, especially if it is bigger one, like 2 centimeter, 3 centimeter, with the medicines like anti-estrogenic medicines, only subtle subcentimetric fibroadenoma like lesions or hyperplasia or fibroadenosis, they may respond to anti-estrogenic treatment like Novex or tamoxifen or danazol. But the bigger lesions, they don't resolve, so they have only two options: either excision or follow-up.
No, actually, there is one more entity, ductal carcinoma in situ. So, if there is lobal carcinoma in situ in core biopsy, we have to confirm it by excisional biopsy. I have read somewhere. And if it is ductal carcinoma in situ, that is a precursor of carcinoma. However, the lobar carcinoma in situ is not a precursor, it is a high risk factor for future malignancy.
Actually, ma'am, I think what you're trying to say is the LCIS, the lobular carcinoma in situ, actually categorized under proliferative lesions with atypia, because the conversion of the rate of conversion of malignancy is slightly less compared to ductal carcinoma in situ, but it is still an in situ malignancy, and there is a significant chance for the lesion itself to convert into lobular carcinoma. So, if we read the classification, some classifications place LCIS under proliferative lesions with atypia rather than in situ malignancies. But lobular carcinoma tends to be bilateral and multiple. So they do progress to malignancies actually. They progress to lobular carcinoma.
Okay. So any problem that you encounter as a gynecologist, ma'am, you may also answer this. Any problem you encounter while you see any patient with a breast lump? How do you manage? What is your approach? By the time I request all my audience, the forum is open for discussion. So if they have any question, they can post in the chat box or they can directly ask the experts. So it is a high time that like we can all interact with each other and can understand each other's view.
If there is no question in the chat
Yes.
box.
Meanwhile, ma'am, I'll just add one more thing. Dr. Mona was talking about chemo prevention. So, if we have diagnosed a papilloma with atypia and they're still not formed into papillary DCIS or there's no DCIS, that patient would be a candidate for chemo prevention to prevent future malignancy. But the same recommendation is not there for sclerosing adenosis or other radial scar lesions. So, if we have on final histology of papillary lesion with atypia, even though margins are free, these patients are candidates for chemo prevention according to American Society of Breast Surgeons, ASBS. So those are one category. I mean, as we are discussing benign breast lesions, so we can give them tamoxifen.
Also ask for IHC, especially ERPR.
Yes,
That
yes.
is positive. Then we do for further risk reduction, we give tamoxifen.
Okay.
Ductal in situ cancers, we ask for
I was talking about intraductal papilloma with atypia.
so it
Still
okay.
don't have DCIS. There is indication for chemo prevention. I mean, since we are discussing benign breast diseases,
Yeah, so it is a risk reducing activity, that risk reduction that we can provide to the patient. Yeah, you are right. Yeah, fine. Thank you very much, friends. So this is a last call for all our audience. The forum is still open for discussion. So we are about to wind it off. If any question you have encountered in your clinical practice, you want just you want some clarification from our side. So our experts is there to help you. And if it is not there, so I would like to thank all the participants for
Should I conclude the session, Sudhi?
Yes, ma'am.
Should I conclude the session?
Yes, ma'am. Yes, ma'am.
Okay. So, living with any kind of breast lesions can be emotionally hard. Those women having them are worried about it turning to cancer. Though this is not the case in most instances, but there still exist a small chances of its conversion. As gynecologists are the primary care physicians to women, and the disease related to breasts are usually examined by them initially. So, a careful breast examination with regular screening should be a part of every routine gynecological examination, either in OPD, antenatal clinic, postnatal clinic, infertility clinic, or gynecological oncology clinic. So it was really a very good session that has given many takeaways to all the participants of the webinar. So before I sum up, I would congratulate each citizen of India for the success of Chandrayaan 3 that has made us stand on a higher pedestal at the global level. And it inspires us not to stop unless unimaginable is achieved. Thank you so much.
Thank
Thank you, Dr. Sudhi, Dr. Ramya, Dr. Rupali,
And thank you very much,
you so
ma'am,
much.
again for
Dr.
hosting our
Mona.
program.
Thank you.
You are a wonderful host, a wonderful moderator, and you really made it. You made it more interesting with your words. And I'm again thankful to all my co-speakers, my guest faculties, my moderator for joining me on my single call and working with me today. I really enjoyed presenting because I learned a lot from this presentation while I was preparing many things as a breast surgeon. Even as a breast surgeon, I didn't know, and I learned it today. And I hope most of the other doctors who have joined us may also have the same feeling. They also had many takeaways with them. They will apply it to their clinical practice. And there are few important announcements I would like to make before I formally conclude the meeting. Is that these meetings are recorded, so or anyone who has missed the meeting may, after some time, we will be uploading it on our YouTube channel. We'll be sharing the link. Please feel free to revisit the program and again refresh your learning, as well as if you feel our efforts are genuine and praiseworthy, please subscribe, like to our channel, uh, give us some comments so that our team feel more energetic and motivated. Secondly, in our upcoming Endo Meet in September, we have very interesting topic. We will be covering the medical legal aspects in breast and endocrine surgery. So please don't miss out that session. I will be circulating about this program in my WhatsApp group. Uh, Come up with your questions so that our expert speaker will be ready to answer all your queries, and so that we can apply those information into our clinical practice again and can benefit from them. And in October meet, as Ramya said, now we will be going to discuss about idiopathic granulomatous mastitis. So those who are hardcore breast surgeons, please save your date and time now only so that you join us on that day. And with this, now I request you all, you may now leave the meeting. And
Thank you, Sudhi. Thank you, Dr.
I
Sudhi,
promise
once
that we
again,
will stay
for
connected.
giving me this opportunity. Thank you, all the delegates. Thank you, Sudhi. Thank you.
Thank you, Sudhi. Bye bye.
Thank you. Thank you.